So next we call upon Dr. Kuldeep Kumar Srivastava. Yeah. He will be presenting on superior rectus transposition for treatment of esotropic DRS.
And one thing, please try to finish in 4 minutes. The 2 minutes आपका discussion and questioning. Okay.
Good morning to all of you. I am going to present my study on superior rectus transposition for treatment of Esotropic Duane Re syndrome. Author has no financial interest to disclose.
Your mic.
As you know, the DRS is described as moderate to severe limitation of abduction, usually esotropia and primary position, anomalous hip posture, and diplopia and attempted abduction. The surgical goal in DRS is to correct head posture, horizontal deviation, globe retraction, upsuit and downshoot, and also to improve the abduction and diplopia-free field. The procedure to improve abduction has been, since long back, it has been the vertical rectus transposition, which is most effective, but it can induce the vertical deviations, and there is a risk of anterior segment ischemia if it is combined with medial rectal recession, making 3 muscle surgery. Then superior rectus transposition described by Johnson in 2006. So purpose of study was to study the efficacy and safety of superior rectus transposition in the treatment of DRS. It was a retrospective study, and Esotropic Duane Re syndrome underwent superior rectus transposition between July 15 and December 22 were included in the study. Information extracted from the case record were pre-op and post-op head turn, pre-op post-op deviation, pre-op post-op abductions 0 to 5. The surgical technique was as described by the Johnson. It was superior rectus transport adjacent to the lateral rectus along with the spiral of Tillox. Augmentation was done with non-absorbable suture and placed at 8 mm posterior to the muscle insertion. No scleral anchoring was done. There was 12 eyes of 10 patients who underwent this procedure. 7 were male, 5 female. 8 has left eye involvement and 2 has both eyes. All has superior rectus transposition with medial rectus recession. All has augmentation sutures. The mean follow-up was 3 years. 3 years, and pre-op, post-op, mean esotropia and primary position improved from 21 to 6. Abduction improved from 3.5 to 2.6, and head posture improved from 20 to 5. Abduction improved in 9 eyes, and 1 patient developed 8 prism hypertropia but resolved spontaneously. This was a girl, 8-year-old girl with left eye DRS1 with ET and face turn. Following surgery, the face turn improved, esotropia improved, and abduction also improved. This was another child, 17-year-old with left eye DRS1 with ET and face turn. Following surgery, ET improved, and face turn improved, and abduction improved. This was a 13-year-old girl with left eye DRS ET. Following surgery, face turn and esotropia improved, but there was not much improvement in the abduction. The full tendon vertical rectus transposition has been the most effective in improving the abduction deficit and range of BSV, but it has been associated with surgically induced vertical deviations and potential risk of anterior segment ischemia, especially if combined with medial rectal recession. Superior rectal transposition, which was described by Johnson, it has the similar result as the VRT, reduces the amount of surgery and reduces risk of anterior segment ischemia. In our study, abduction improved in 9 eyes, which was similar to the other studies. 1 patient developed surgically induced hypertropia, which resolved spontaneously. This was probably due to the inadequate dissection of the superior rectus muscle. To conclude, superior rectus transposition is a safe and effective procedure for improving abduction in esotropic Duane Re syndrome. Thank you very much.
So SRT for DRS ESO is known already. So anything new you are adding?
It just I did the same procedure which has been described.
Okay.
So your the esotropia range from 15 to 30 prism diopters.
Yes, sir.
So, but you have done MR recession with superior rectus transposition with Foster in all patients.
Yeah.
So, don't you think a patient with 15 versus a 30 prism diopters would have different results? I mean, some surgical strategy should be altered rather than doing both the procedures in that patient.
Actually, less than 15, I am avoiding this procedure, and above 15 prism diopter, I am doing this procedure. And so far, I have not gone any over. I have not got any overcorrection.
Did you have limitation of adduction in some patients? Because one of the photographs was showing.
Yeah, it's
pre-op.
we are getting -1 adduction.
Any next time any clip, if you add any clip, then this is for good literature for viewers. Some little clip, even 30 seconds, is more meaningful than the, or even photograph than the sketch.
Okay.
Is more meaningful to the scientific deliberations or papers.
Okay.
But otherwise, very good. Very people are doing all these things. So, very nice presentation.